All right, good afternoon. I'm Jason Samuels. I'm a chief resident at the University of Colorado. We really appreciate the opportunity to present our work today. We have no relevant financial interest to disclose. I'll take my 7 seconds to say apologies for the weather here in Denver, unless you have ski tickets tomorrow, in which have a great time and enjoy the powder. I think that was 7 seconds. All right. So we all know that bariatric surgery is the most effective treatment for severe obesity, but its uptake remains limited, with an estimated 1% of patients who would otherwise qualify actually undergoing surgery. And that's due to a variety of factors, but one certainly is concerns around cost effectiveness. A number of studies have looked at this concern for cost effectiveness, including this study by Clark and colleagues, which compared a bariatric population to a matched cohort who did not undergo surgery, and found that, sure enough, within the first 2 to 3 years after surgery, the bariatric surgical group had a higher degree of healthcare costs compared to that non-operative cohort. Certainly, the surgery itself contributes to that increased cost, but it doesn't explain the entire difference. So what explains why bariatric surgery costs so much within those first few years? One is theorized to be the increased frequency at which patients utilize the ER after bariatric surgery for an extended period of time. And a number of groups, including our own, have looked at this, and our group published last year in SWORD, comparing a 1-year preoperative baseline across a population of bariatric patients, the frequency at which they utilize the ER in the postoperative period. And sure enough, we showed that within that first month after bariatric surgery, there's a significant increase in the frequency of emergency department visits. But importantly, that frequency or that increase persists for a full 8 months after surgery. So what should we do to try and reduce this emergency department utilization rate? Of course, the easy answer would be to increase the frequency of follow-up and enhance our telehealth strategies, but that in and of itself would be cost prohibitive. So ideally, we would try and determine which patients we would be at most at risk for a post-operative emergency visit. And a number of studies have identified risk factors thus far for a higher risk of utilizing ER post-op, including younger patients, female patients, and unsurprisingly, those with a variety of comorbidities. Groups have also surmised that maybe psychiatric diagnoses put people at a higher risk of utilizing the ER postoperatively, and 2 studies by Fisher and colleagues and Kim and colleagues estimate about a 60 or 70% increased risk of utilizing the ER in a period of 3 months to 1 year after surgery. What really remains unknown is why this group with psychiatric diagnoses would utilize the ER more. So the aim of this study was to determine the incidence and causes of emergency department usage following bariatric surgery in patients with underlying severe mental illness, specifically bipolar disorder or schizophrenia. And we hypothesize that patients with the mental illness will in fact have an elevated rate of ED visits following bariatric surgery when compared to a matched cohort, and that this will be due to poorer control of common post-operative symptoms. Briefly about the database we use, we utilize the Colorado All Payers Claim Database, which is a statewide insurance database. It includes both public and private insurance programs and encompasses about 2/3 of all of Colorado's insured population. For the study, we included patients who underwent laparoscopic sleeve gastrectomy, adjustable gastric banding, and Roux-en-Y gastric bypass. And for the sake of this analysis, we only included patients who had a full year preoperative data and 2 years of postoperative data. We excluded patients whose index bariatric surgery within the data set was a revisional surgery and those who were younger than 16 years old. Our primary outcome of interest, of course, was the frequency of ER visits, and our secondary outcome of interest were the diagnoses associated with these visits. We compared 2 groups. The experimental group was that psychiatric group, and we only included patients with pre-existing what we called severe mental illness, specifically bipolar disorder or schizophrenia. We utilized those diagnoses because we wanted diagnoses that were likely to be chronic and unlikely to be situational or impacted by bariatric surgery itself. And along those lines, we excluded patients with other concomitant psychiatric diagnoses. And then, of course, our control group were patients who had no preoperative psychiatric diagnosis. We matched these 2 groups in a 1-to-1 ratio across age, sex, BMI categories, procedure type, and comorbidities. Our data set included 5,500 patients who underwent bariatric surgery over a 5-year period, and after application of inclusion-exclusion criteria, we arrived at 240 patients who had isolated bipolar disorder or schizophrenia. This was matched to a cohort of 3,350 control patients, and we were successfully able to match 235 of those within each group across all variables. And you can see in the table at the bottom the distribution of surgeries utilized, and this largely aligns with national trends within the United States. This graph shows the emergency department usage both at baseline and after surgery, with the blue bar representing the preoperative baseline of the control group and the red bar representing the preoperative baseline of the psychiatric group. And you can see that before surgery, there's already a 60% difference in the frequency at which these patients utilize the ER in a 1-year period. Interestingly, the psychiatric group has a nearly 2-fold increase within the first month after surgery compared to the 1-month post-op in the control group. And what's more important, or what's more interesting, is the fact that unlike the control group, which has a fairly rapid return to its preoperative baseline, the psychiatric group experiences a higher rate of ER usage above its preoperative baseline for a full 2 years after surgery. We tried to identify potential explanations for this difference. There's a bit of a signal when it comes to diagnoses related to psychiatric issues tied to these ER visits. Of course, at baseline, there was a difference between the two groups, with the psychiatric group experiencing more, but only at one time point in the post-op period was there a statistically significant difference between these groups. In contrast, abdominal pain, diagnoses associated with those, at no point was there a difference between the two groups. Similarly, there's no difference between the two groups for ER visits either before or after surgery related to nausea, vomiting, dehydration, and there was no difference at the rate of ER visits associated with bariatric complications. So we can summarize that patients with pre-existing psychiatric diagnoses were more likely to utilize the ER both before and after surgery, and that increased ER usage actually persists for a full 2 years post-op, and that these visits were really not due to the underlying psychiatric issue at hand, nor were the visits due to common symptoms related to bariatric surgery as far as we can tell. We can't conclude that patients with underlying mental illness would benefit from targeted, intensive post-operative follow-up. Still, it remains unclear why this subgroup of bariatric patients utilize the ER at a higher rate, and I think one potential explanation, certainly an area of future study, would be whether access to healthcare explains some of this difference. And a number of studies have looked at patients with psychiatric diagnoses having fewer visits for health maintenance, things like cancer screenings, adjustment of medications for common comorbidities. And then, of course, it would also be interesting to study a number of methods to try and minimize these ER visits, including enhanced preoperative teaching, further subgroup or determinations of subgroups to identify who would benefit from these follow-up programs, and then identification of a rapid action program where we identify these patients at the time of potential ER use and trying to steer them to an equally effective but more cost-effective strategy. Greatly appreciate everyone's time and attention and the support from our colleagues, and I'm happy to answer any questions.